This panel is going to be moderated by Dr. Jason Foster, who is a GI surgical oncologist from the University of Nebraska Medical Center. Next to him, we have Dr. Hedy Kindler, who is a medical oncologist. She's the director of the multidisciplinary mesothelioma program at University of Chicago, and she specializes in GI malignancies. Next to her, we have Dr. Georgios Karagkounis, who's a GI surgical oncologist at Memorial Sloan Kettering Medical Center. And next to him, we have, again, thank you, excuse me, Dr. Michael Offin, who is a medical oncologist who sees several peritoneal patients, and we thank you. He's from Memorial Sloan Kettering and is co-director of their mesothelioma program, and we thank you all. Let you get started.
Well, thanks, man. Thank you, everyone. Glad to have you guys here. How many of you guys were here yesterday for the tumor board? So a good chunk of you guys. So there will be some overlapping information about the science and things. But I think our plan here is to jump into some cases. We've got a number of cases that I think cover a lot of different scenarios with which patients present. And we go through the different treatment options. And we're going to try to hold the questions at the end of these. But if there's something pressing, we can probably address them within the cases. So I'm going to start off with some straightforward information. So if you guys were here yesterday, I think some of the just rules of the framework of a tumor board is, so we're thinking about patient options, patients for surgery, even patients for medical therapy. Is first thing is medical fitness. Can you tolerate what it's going to take to get you through this? And from surgery, there's a set level of fitness you need to be at to be a candidate. Obviously, for medical treatments, my colleagues from the medical oncology side, there are things that they can do to adjust to your level of function and fitness with the several options that they have. Some of the factors that go into this are the tumor types. We talk about the different histologies. From a surgical selection standpoint, the tumor burden has a huge impact. I'll talk a little bit about the peritoneal carcinoma index. And aside from that, the distribution sometimes independent of the peritoneal carcinoma index that plays a role in this. And then how we use chemotherapy around surgery, the timing, the different agents. There are things beyond chemotherapy, immunotherapy, biological therapies that the panel will discuss, how certain mutations can impact this, particularly germline mutations impact decision making, and then the role for managing symptoms within this disease space with the goals of surgery is one thing that comes up, and other tools that we can use for patients. So I'm going to start off with a fairly straightforward case. It would be ideal if all of our patients had this type of case, but this is the typical scenario of a patient who comes in, and we'll talk with the panel and get their opinion on this one. So this is a 45-year-old woman who comes in with vague abdominal pain that's been going on. She gets checked at a local ER. There's concerns for gallbladder disease or kidney stones. So a CT scan's obtained. And there's this evidence of, let's see if my mouse comes up here. It doesn't look like it's projecting, but there's these nodules here up on the omentum that prompt a concern and a referral to a general surgeon. So I will talk to Giorgio. So if you get this patient and you actually get the first opportunity to work this patient up, how would you proceed in terms of working this patient up?
Great, thank you. So I think you touched on all the key parts already in the brief introduction about the importance of understanding where the patient is, both from a symptom perspective and a overall clinical status, performance status perspective. Because unfortunately, what we do see sometimes, and this may not be a good example of this, is patients have been going through a lot until they were diagnosed, and that has taken a toll on them. It's taken a toll of their ability to tolerate certain treatments versus other treatments. So it's my first approach to this is usually trying to get a sense of where we are. And if we are fortunate, and this is somebody who caught it fairly quickly, incidentally as in this case, and we expect that they're in a good performance status and this hasn't impacted them, then we move on to the next part of it, which is to determine which of the combination of treatments you mentioned is going to be the proper one for them. And as a surgeon, of course, I focus primarily on whether that is one that should be part of the conversation early on, whether it would be part of the conversation later on, or whether there are indications that even though this person doesn't have any other medical problem, surgery may never be the right answer.
Great. So in terms of how you acquire a diagnosis from a tissue standpoint, do you agree with CT-guided biopsies versus other modalities that you might go after getting the diagnosis?
I think I was so focused on the conversation today, I didn't realize we didn't have a diagnosis yet. But
Yeah, that's okay.
This also happens sometimes in my clinic. I'm so used to people having already had the biopsy that occasionally that can be the problem. But to your point, I think you bring up an excellent point. When we do see peritoneal involvement like this, and we don't have a clear source, there's no other reason to suspect that there's a primary neoplasm anywhere else, we start with a percutaneous biopsy, because this, of course, this being a mesothelioma symposium, we're all thinking of that one diagnosis, but there's a very broad spectrum of different reasons that can have a same imaging, and then, of course, there are very different treatments down the road.
So these are the nodules we're talking about. So again, in this case, often these patients come to us from other facilities and things have already been done. And just as Giorgio said, CT-guided biopsies are commonly used. Sometimes there's fear about tract seeding and other things. When you have peritoneal disease, we don't worry about that as much. Honestly, the way that these things are required in imaging, they actually have a housing that comes down when they do the core needles to reduce the risk of any type of tract seeding that sometimes people talk about with obtaining these biopsies. Similarly, if we get these, we might sometimes take patients for a diagnostic laparoscopy. And my approach, and I will see what Georgios thinks, I tend to put all of my trocars in the midline if we're going to take biopsies. Kind of standard laparoscopy is to triangulate, you go off midline, but sometimes that can be a problem with some tumors that are a bit more aggressive with trocar implantations. So we make an effort to put these things in the midline, which we're going to use that approach usually when it comes to surgery, so we can routinely remove those. Is that your approach too?
Laparoscopic approach, I agree with you that especially for the ones that tend to seed the tract as much, it's a very good point to try to keep them in the midline, so in a subsequent surgery it's a lot easier to excise that area, so I think that's what you're alluding to. Now the question that I have for you, I guess, is in this context with not a clear diagnosis up front, would you favor a laparoscopy or would you favor the percutaneous?
You're jumping right ahead to my next point. So, but before I do that, and this, I guess, to my medical oncology colleagues, the other thing that I always want to do, and I think we all do this routinely, is get the path reviewed at our institution and how that's of critical importance. Hedy, if you want to speak to that, which we did.
Absolutely. I mean, as I always tell my patients, mesothelioma comes in 3 flavors: epithelioid, sarcomatoid, and mixed, chocolate, vanilla, and swirl. And while in the chest it's more common to have swirl or chocolate, sarcomatoid or the mixed, in the abdomen the epithelioid really predominates, and almost all of them are. But sometimes it's also not a malignant meso, and it is what we used to call a well-differentiated papillary meso, now called a well-differentiated papillary mesothelial tumor, or basically something that's benign and never going to come back, and you really want to know that before putting somebody through a massive surgery and chemotherapy and immunotherapy. So it's very important. It's also important to look at the grade. Is it a mellow vanilla or is it a more aggressive vanilla? And that may also give you some characteristics that may tell you that maybe we should give treatment before we go with surgery. What's the biologic behavior of that? We'll look at what we call the molecular on-off switches, the next generation sequencing, which can sometimes help us identify certain targets. And so, there are a lot of things that we want to be looking at in that pathology, and meso is tough to diagnose. So a disease that affects very few patients, 250 to 450 patients a year, most pathologists have never seen. You want to make sure that you've got the diagnosis right before you're proceeding with something big.
Perfect. Mike, go ahead.
Yeah, just to kind of dovetail on that, making sure the pathologist who's looking at this is meso knowledgeable is important. So at our institution, anybody with a mesothelioma diagnosis of concern is reviewed by a specific thoracic oncologist, pathologist rather, even if it's in the abdomen. And I think that's of the utmost importance. I always tell my patients, I'm only as good as my pathologist. You rely on that diagnosis.
100%. So in this particular case, and I think we've alluded to it, so I'll jump right to it, The next steps in the management would be, one, we know that the outside CT scans are often more diagnostic, so we tend to want to get a high-quality scan. At our institution, we use both high-quality MRI and thin-cut CT scan. I think it's also important and critical to emphasize that we want to see the chest. We want a high-quality baseline chest CT. To Hedy's point, that we don't want to take anything for granted. These patients may have two-compartment disease, which changes the whole context, independent of the flavor of disease you're dealing with in the decision-making. And then, to Georgios' point, you know, we prefer to do laparoscopies on our patients to know exactly what we're getting into, because these scans can often underrepresent the disease. I tell them 10 to 20% of the time I'm going to find more, probably higher, and sometimes it's significantly more, and the laparoscopy can be a way to sort of control that. My approach is that I tend to disaggregate the procedure, because if I do find this type of disease, or if I want to frame the conversation of what it's going to take to do this operation, we can sit down and have that with the patient. It can be a bit stressful if you do these as a single procedure and then you're talking to family members about the unexpected ostomy that becomes required or some other things. You can have these conversations, and which we end up doing, covering all the bases, but it's always good to have the pictures as well as the details that patients are about to go through with these larger cytoreductive procedures. And I think, unlike the presentations yesterday, surgery becomes a fairly significant part of management in this particular disease in the peritoneum.
One quick tangential aside, usually at the kind of this diagnostic stage, we would take any person who is of reproductive potential, and this would be the time to discuss any kind of like fertility preservation. This is like the portion of the workup. So it's always important to say this disease has a somewhat different demographic makeup, younger individuals. Discussing that is not a small endeavor.
Yeah, I think that's critical importance there as well for folks in preserving fertility, both male and female, in terms of making sure you preserve that in some way.
One thing, as before we move on to the imaging, because it's going to be a little bit related as well, is sometimes my patients will ask me, oh, if we have great MRI, CT scans, et cetera, why do we need the laparoscopy? And the reality with a lot of these tumors, and certainly a large amount of or number of the peritoneal mesotheliomas, is they don't always grow truly in 3 dimensions. They often grow in 2 dimensions, and our imaging is not particularly good at picking up something that, if you look at it from the side, it's very, very thin. So that is what the laparoscopy achieves. In addition to that, is it gives you a very good picture of what would be, if you will, the wallpaper on the wall, which you can see from one direction and it looks completely clear, but from the side it almost looks like it doesn't exist.
Good point. Well, in this case, we did find, again, some residual disease or visible disease in the pelvis that I can show you here. So you can see these little white spots. So sometimes there's a T2 signal and some other things that we do, I won't get too technical, that allow us to see these high water content tumors that these often can sometimes stand out on MRI, which makes it nice. I don't think any modality, MRI or thin-cut CT scan, is superior to the others, but I do test them in both to see which one is the best option for each patient. I personally don't find PET CTs just as described. These tend to be thin lesions, small. They sort of often fall under the detection sensitivity of PET CTs. They can have a role, but it's not something that we often use in the planning for patients generally. So the next steps, and we won't belabor this point, this is the patient you take to the operating room up front, a healthy patient with a peritoneal carcinoma index of 10, which is fairly low, and we'll talk a little bit about that. And we go for cytoreduction. Again, the PCI of 10 sounds low, but I put up this is some of the things that we took out of the abdomen, but it becomes a pretty extensive list in terms of interperitonectomies, taking out the omentum, often the spleen, sometimes taking little side bites off the bowel or doing formal bowel resections, taking the appendix or standard parts of this procedure. So it's a fairly significant endeavor, and this is all consolidated with the intraperitoneal chemotherapy, which has been quite beneficial in terms of adding to the peritoneal control level since we've added it to the regimen. So again, you see a path that comes out like this. This is pretty typical in terms of multiple sites of varying size on the final path. We achieve an optimal resection where there's no visible disease that I see with my eyes, and this is where you would want to get with this type of patient. Just to talk about the peritoneal carcinoma index, to cover this for the group, if you guys have been on the internet, I'm sure you've seen pictures of this. Again, quickly, it's the 9 zones of the abdomen plus 4 around the small bowel that come around. The lesion size is something as surgeons, we get experience with this. We can recognize 5 millimeter lesions versus 5 centimeter, and then those that are over. To Georgios' point, often it's not just this big 3-dimensional thing, it's a long sheet of flat tumor that's defining it. The diffuse nature of the tumor versus the disaggregated nature where it's separated is a factor in the scoring, and we do kind of add up those aggregates that are flat in terms of staging this out. So from my perspective, a PCI under 15 to 20, I would consider on the low to medium side, and these are the patients I would routinely take up front. Once you get above 15, 20, I'd say 15 to 20 can be a gray zone depending on where the tumors lie, particularly if it's all along the small bowel, mesentery, and some of these other areas that are pretty challenging to clear, or if you clear them, you're gonna leave people with not a significant function of their bowel if you go after it, and there's value in terms of using neoadjuvant therapies to change that paradigm. At the end, it's the reverse. So what did I leave behind? Did I leave nothing? The score kind of gets a little tighter in this part where you want to leave lesions, at least if you use the CC score, which most of us do, where you want to get lesions down to 2.5 millimeters or less is ideal. Another score that's been out there, and this was the older score, some of the surgeons out there still use it, is 5 millimeters. I think it's a bit of a hair split to say 2 to 5 millimeters. You get your visual microscopes out of your eyes to try to distinguish between 2 and 5, and you're making your best call. But I think equally important to that is the distribution. Like, are you leaving 2.5 millimeter disease in a huge surface area? They're still equivalent, it's still individual nodules, but there's a different perspective in terms of where these patients are gonna land with their outcome and what you might do for them. But the goal is to get people into these 2 categories at the end of a successful cytoreduction. And then just an example out of the SOGI guidelines. So they get together periodically and compile the data, but we know completeness of cytoreduction and the PCI score are by far the biggest factors in how patients do after surgery, and these have an impact on our decision-making in terms of adjuvant therapy. So I would ask the panel, you have someone who has, and I'll just add the Ki-67 on this case was like 1 to 2, was very low, which I didn't show in here. It gets optimally cytoreduced. Would my oncologist want to treat this patient? Because we're always going to send these patients to our medical colleagues. We're going to discuss them in multidisciplinary conference afterwards. Is this someone you feel we would just watch, or would you want to offer any therapy for a case like this?
So I would want to know what is the patient's gender?
Female.
Female, okay, because women will do far better than men and tend to have much more indolent low-grade disease. Was the pathology low grade? You're describing from the Ki-67, it was low. Was it a relatively low grade on a 2 or 3 grade scale low?
That's right, it was a 2 in the middle.
Okay, all right. And you had a CC01.
CC0.
CC0.
PCI 14.
Perfect. So this would
And HIPECT, always.
These are the types of questions that the surgeon and the oncologist are going to go back and forth on. Yeah. And sometimes it's not even...
I feel like I'm in tumor board, by the way.
Exactly, that's what the tumor board or the
That's right.
cell phone,
That's right.
And so based on all of that, this is somebody who has a good prognosis and would be someone who I would have a discussion about adjuvant therapy, adjuvant meaning put the weed killer on the lawn so the dandelions don't grow, but would favor observation over treatment because this person is going to do well and might not need chemotherapy for a few years, if at all. And so this would be a person I would have that discussion with, weighing the pros and cons, but would not be inclined to offer surgery.
I would echo that. And then the other thing I would mention is if there was genetic sequencing like BAP1 inherited germline, they also put you more towards the let's watch after surgery.
Perfect. So was a somatic BAP1, but not a germline BAP1 on this one. Excellent. So just to mix it up, so same case, initially biopsied, and this is a real scenario as epithelioid, but achieve a similar PCI CC0, but now the tumor comes back as sarcomatoid type on this patient. Again, same level of cytoreduction, otherwise female, around the same age, and these are actually 2 cases that I encountered. How would you guys approach this from a medical standpoint? You want to go, Mike?
So I have a patient, we were actually just discussing that this happened to. We offered in that setting, again, it's a shared decision, but I think that's a more aggressive histology and it changes things substantially. We offered adjuvant immunotherapy, and luckily this patient actually did quite well.
Yeah, this is always a difficult decision because there is data, at least, on giving postoperative chemotherapy. There's far less about giving postoperative immunotherapy, but you do know in general with a sarcomatoid meso that it's going to come right back. So it's almost what we would think of as pseudo-adjuvant. It's probably there and we can't see it. And so I would also be offering that, the immunotherapy in that setting, but really having a clear risk-benefit analysis with that patient.
That's great. So I think this one, our oncologist ended up giving chemo and immuno 4 cycles, I think, and immuno for 6. And both patients are doing well. The one's an 8 or 9 year survivor. This one's about 3.5 years out. So great. Now, I just add, if you had gotten this biopsy, even in an optimally resectable patient, what would have been the thoughts on the role of neoadjuvant therapy once you see this histology in a female? Would you prefer to give neoadjuvant, or would you prefer we go inside or reduce? What would you guys?
In a sarcomatoid meso, I would offer immunotherapy up front. And the question of whether or not to resect is unclear, but could be left open as an option for that patient with limited disease, particularly since sometimes with immunotherapy you have these really dramatic responses. So you could offer that, but again, you need to weigh the pros and cons of surgery in that setting.
It would be the way I frame it. I would say we would give immunotherapy, and if there was a robust response, we could discuss the non-standard use of a resection, but I wouldn't necessarily call it like neoadjuvant in that setting.
Gotcha. All right. So again, this is just a slide that shows this consolidated data, how important histology is in terms of sarcomatoid or biphasic. This case would have been biphasic because it had both types, the vanilla and chocolate swirl, as Hedy was discussing. And it's clear that this has a high impact on the behavior of the tumor, even when people are surgical candidates. And I would agree, I would take anybody with high-grade features and test them with systemic therapy before we subject them to a big procedure that we perform in these scenarios. So I'm going to table that and move on to the second case. Again, this is a patient, now male, 50-year-old, with an umbilical hernia, otherwise feels fine, asymptomatic, but the hernia is getting bigger, sees his local general surgeon. The local general surgeon is planning a laparoscopic procedure, and then when they actually get in there, they find diffuse disease. So interestingly, most general surgeons don't scan patients who present with hernias, they just take them in. So they had no idea what they were about to have. So I'm gonna kind of show you the scan, which kind of shows some of the things that come up. So this is the hernia, and there is some nodularity and firmness there. This is what you'll often see called omental cake. I'll just kind of keep coming down here. Yeah, you can see it more clearly here. And what I kind of buzz through is there's all these little etchings and changes along the mesentery of the small bowel diffusely that when I see that, there's this sense that there's a diffuse process going throughout this abdomen. There was a little bit of ascites up by the top of the liver. And then if I keep coming down here, you're going to see you get this thing in the pelvis as well, which is a big implant. So as much as we use CAT scans, I'm surprised at all the things that CAT scans get done. Often our general surgery colleagues will bypass that, and that's okay, but they paused, didn't try to fix the hernia, got some biopsies and confirmed this to be a higher grade malignant peritoneal mesothelioma for this patient. So I guess I would ask my panel, you have somebody who's now got a CT scan with a PCI in the high 20s that shows up fairly asymptomatic with this disease. What would be the approach?
This is, as you said, a contrasting example compared to the last one. You have now much more concern just looking at the pictures. And I'm assuming, so that I don't fall into this twice, we do have a path diagnosis this
We
time,
do.
right? Okay,
We
perfect.
do.
And also, this is probably more of a surgeon's joke, but I hope they didn't fix the hernia with a big mesh at the same time, because I have seen that where somebody will encounter something unexpected, still do the hernia, and then makes our lives a little bit more complicated. But all that aside, now you're looking at someone whose surgical intervention, even if, and as Jason mentioned before, we usually find more in the operating room than what we can see on the scan. And even if we didn't find more in the operating room and we just found exactly what you can see on the scan, it would be a very substantial operation. It would involve several different parts of the GI tract, potentially other organs. So that would be a big price to pay to go through that operation. So when that happens, in my mind, my thought is this operation going to be giving us a benefit that it justifies the price that the patient is paying for that operation by having a prolonged recovery, by having potentially changes in function that are going to be substantial? And it is not immediately clear to me. And that's where we sometimes have this conversation with Mike, for example, is should we try something first to give us a sense of where this is headed? If this is something that is more aggressive or less aggressive. And then secondarily, also, can we do something to make this from a more substantial operation to a less substantial one by decreasing the size of these tumors or the involvement or anything of that nature? This is the part where Mike answers.
Can I just say I agree?
Ditto works.
I mean, in general, surgery should be considered for all. Interdisciplinary discussions have to be had. In a case like this, Gio and I would have a quick conversation where we would both pretty much agree that we should give this person something systemic. If there is a good response, we could always consider it later. But with disease like this, that type of a surgery, it's probably risk versus benefit favoring risk substantially.
One thing to clarify is it doesn't always mean that technically this is not something that can be done, that the surgery for this cytoreduction cannot be done, but it is at least the way we think about this in our group. Do we have enough proof that if we do it, even if it is successful, it will be beneficial? So I think this is the difference sometimes, because we all have different opinions, different specialists see this differently. And somebody could say, no, I see everything I can see there potentially can be taken care of in the operating room with this, and this. And then HIPEC or your type of IP abdominal chemotherapy can take care of the rest. The question is this the right answer for this patient? Do we have enough to say that this is the next step that we would recommend?
It's not just can I do it, but should I do it? And I always ask my surgeons, so what is the likelihood that you're going to be able to get a CC01 cytoreduction without major morbidity and mortality? And if you can get that CC1 cytoreduction, would it be easier if I gave some treatment first to cytoreduce that?
Yeah, and to play off what Hedy just said, that's exactly what we're always thinking is, one, can I get it done? And even if I get it done, can the systemic therapy make the lift lighter in terms of what I have to do and what I can offer these patients in terms of getting in there? I think the other thing is having somebody who gets neoadjuvant therapy and you can show control, particularly reduction, is a confidence builder that we're on a path of success in terms of not just getting this done, but your prognosis of being able to have some durability of what we're going to do here to benefit you. Not to mention the short-term risks of the procedures. We don't want to subject people to that. And it's also clear that getting neoadjuvant therapy in before the big assault of surgery is much better tolerated. You're going to get that patient guaranteed on those, and you have some sense, if depending on what you find and you need something on the back end, did it work as well as you thought it did? And if there's a need to go back on it, if you think there's a consolidative value at the end of this, it's there for you as well. So this is exactly what we did and what we would offer these patients. Kind of have a little caveat with this case. So this patient went on and got treatment, and we saw them after the first 3. And let's see here. You can see the mass got smaller, feeling good, looking better. The read was all very positive. But as we get ready to get teed up for surgery, this happens. The week before surgery, a huge saddle PE occurs, which we know, unfortunately, patients can have other unrelated problems. This can be something that leads to hypercoagulable states. They were able to do a vacuum-assisted thrombectomy. Patient went on Eliquis and actually did great. So when you face this, you face an obstacle to getting to surgery, what would the panel do? Obviously, we don't want to take a patient with an active PE straight to surgery. we know that our surgery is going to be even more clot provoking, so we need to pause. So if you have somebody who's having a good response, what would be the thoughts at this point? So we obviously cancel surgery, take care of the problem.
I would treat to maximal benefit up to 6 cycles and buy time.
Yep, and that's exactly what we did here, and it actually worked out. So this particular provider decided to drop, which I think was reasonable, the permatrexate, and switched to carbo in light of all of this. But the patient went on and had an even better response in the pelvis, which is going to make this a much more, I won't say better, but still the surgery in terms of getting to the goals is going to be much more successful. So this patient, when I return after this meeting, will undergo their cytoreduction. But I thought this was a perfect example of not just how neoadjuvant can benefit patients, but how we adjust to the medical issues that occur for patients. So we're going to skip that. And I'm going to yield this podium here to Dr. Kindler, and she's going to provide a case about two-compartment disease. You guys heard about it yesterday a little bit. You heard it from the pleural side. So just to briefly sort of tell you about it from the peritoneal side, when you have people who have both disease in the peritoneum and in one chest cavity, or sometimes both, or pericardial, what do you do? In my mind, when you're thinking about patients who might be surgical candidates, there's kind of 3 scenarios. They can present with both, and they can present with isolated peritoneal recurrence after management of something in the chest, and then they can present with more diffuse disease. This is where Hedy will talk about the impact of BAP1 status and germlines that can come up and impact this. And I think, we're highly selective in this group of patients, but at the core, if you don't have disease amenable to surgical clearance, and if that surgical risk is absorbent, you're not going to have a surgical option in bicompartment disease. And I think when it does come up, I think it's a challenge for us. If people have already had a major lung resection, or if you have bicavitary disease that you think is of surgical consideration, you tend to want to do the peritoneum first, because once you do a pneumonectomy, the anesthesia around pneumonectomies, even for elective procedures, and I think this is all our peritoneal group, like the idea of one lung ventilation gets very challenging, and it's an issue in and of itself to take patients who have had a major pneumonectomy to the OR, because a blowout of that stump can just be devastating for a patient. So you have to be really thoughtful in terms of what you're going to do in these scenarios. So I will yield and let Hedy.
Okay, so in 2011, this young gentleman developed some reflux symptoms, nothing abnormal. He, for some reason, underwent an ultrasound, and it showed ascites. He had a paracentesis, he had a CT scan, and these failed to identify a cause. He was following with a primary care doctor, and he had really no other symptoms, and so his doctor followed him with yearly abdominal ultrasound. It comes to be 2016, and the ultrasound was showing some increase in fluid, and they removed 2 liters from a paracentesis. At this point, cytology, the cells in the fluid, revealed a mesothelial proliferation. In other words, something's abnormal but doesn't look quite like cancer. So we're now 2 months later, in June 2016, they do a CT scan finally, and it showed omental caking. The apron on the abdomen had disease, and it was suspicious for cancer. There was also a very tiny right pleural effusion fluid around the lung and a very tiny right pneumothorax. So that's an air leak between the lung and the chest wall. And this was later compared to a CT from 2011. And now, in retrospect, they saw not only the ascites, but also some abnormal omental density. So he had this even back in 2011. Gives you an idea about a slow natural history of this disease. So he finally undergoes a laparoscopy, they put a scope inside, they do an omental biopsy, and lo and behold, the pathology revealed an epithelioid mesothelioma. He had a PET CT, which showed, and I don't do them either, but this was ordered elsewhere, and it showed a diffuse uptake associated with omental caking, peritoneal thickening, moderate ascites, and mildly increase in that small right pneumothorax. He then was referred to our mesothelioma clinic. So our pathology review, indeed we always review the pathology from the outside, and it confirmed an intermediate grade epithelioid mesothelioma. We now have a 2-stage system, low and high grade. In those days it was a 3-grade system, so this was in the middle. We standardly do germline testing on all of our patients, and this revealed that he had a germline BAP1 mutation. When we looked at his exposure history, because we take an occupational history from all of our patients, his father worked in a boiler room at a pharmaceutical company and was around steam pipes, boilers, and asbestos. So he had both a germline mutation and para-occupational exposure. His dad wore his work clothes home, and he was exposed that way. BAP1 is what we think of as a gene-environment interaction. So maybe you have a lower threshold for developing the cancer, just like I have a lower threshold for developing sunburn when I'm out in the sun. So he also had multiple family members who had cancer. We know that patients with germline mutations tend to be young, tend to have more commonly peritoneal disease, and have multiple family members with patients with cancer. So we had a discussion regarding preoperative, or what we'd call neoadjuvant chemo, or upfront surgery. And the decision was made at that time that he received neoadjuvant chemo because, one, and I think most important, his wife was expecting a baby in 2 months, and he didn't want to be recuperating from surgery at the time of the birth. This occurs in young patients, and there are other family issues that are involved. And secondly, the presence of that tiny pneumothorax suggested that we were concerned that there might be disease outside of the peritoneum. A spontaneous pneumothorax is a not uncommon presentation for a pleural meso, but it just didn't quite merit doing a thoracoscopy at that point. So he received what was standard at the time, pemetrexed, a platinum, and bevacizumab. He had some toxicity from bevacizumab and had to stop it, so continued on just pemetrexed and platinum. And one does also have to hold the bevacizumab because it can affect clotting and bleeding before you're going to do a surgery. Now, the scan just showed stable disease. He hadn't actually had any tumor shrinkage. So we're now in November, and he underwent a CRS HIPEC, so the cytoreductive surgery with the heated chemotherapy. And at that time, the PCI was 39 on a scale of 0 to 39. So he underwent a CC1-2 cytoreduction. Some areas were CC2, others were CC1. This was clearly an incomplete resection. There was confluent disease over the mesentery of the bowel, which could not be removed. And he had a prolonged operative recovery, and he opted for observation afterwards. We had a discussion. You've got disease left. Do you want to get treatment now or not? This was before immunotherapy was standard of care. He'd had a prolonged recovery. He had young children, and he had disease that he knew had been there since at least 2011. So it was reasonable to offer observation in the absence of very active therapies and having such indolent disease. So the next summer, he had a recurrent pneumothorax, and at that point, we did a thoracoscopic pleural biopsy. And I remember my surgeon describing it as very thin and filmy, like you could barely really identify it there, but the biopsy did show an epithelioid mesothelioma. So he now had proven bicavitary disease. In August of the next year, he underwent a laparoscopy to better assess a concern for disease progression, and it showed no evidence of disease, just ascites, and continued observation was recommended. This was a little bit strange, but hey. So then in January of 2022, we are 4 years out, he finally has some disease progression on CAT scan. Laparoscopy again showed that PCI of 39, and he clearly was not considered resectable. So he was now offered chemotherapy, immunotherapy, or a clinical trial. How do we decide? Well, chemotherapy, his disease was at best stable from it, although maybe he had a delayed response, we don't know. He had a tough time with it, and he was not eager to resume it. Immunotherapy was, at that point in time, challenging to obtain from an insurance perspective for peritoneal meso, as it was approved only for pleural, and there was limited data on it in peritoneal patients. And a trial that Kiran Taraga and I were running concurrently actually showed an increase in ascites fluid in these patients getting immunotherapy and some other challenging issues. And so we were a little reluctant to offer that to him, but his insurance basically wouldn't let us anyway. Or a clinical trial. At the time, we had a clinical trial of a drug targeting something called EZH2. And this was specifically for patients with BAP1 mutation, so it looked kind of perfect. Basically, if BAP1 goes down if you have a mutation, EZH2 goes up. And so this drug brings EZH2 down. So sounded pretty good. It did have a lot of side effects, including diarrhea, abdominal cramping, altered taste, skin rash. And however, he had stable disease for another year, a little over a year, when his disease finally progressed on CAT scan. But at that point, he was requiring monthly paracentesis, and he had recurrent GERD. Basically, thank you. Thank you so much, Julie. Definitely a caregiver. All right. So for him, whenever he would develop GERD, he would know that he needed a paracentesis. And so he was requiring monthly paracentesis, had recurrent GERD. So we first wanted to see, is there a surgical approach that we could use? We knew he wasn't a surgical candidate, but is there a surgical approach that we could use short of a CRS HIPEC that might palliate ascites? We know that the CRS HIPEC itself can control ascites well, and for a durable period, laparoscopic HIPEC, where you put a scope in and you put the heated chemotherapy in, can sometimes control ascites fluid. And so that was what we offered him. These days, we're also doing PPAC, where you spray the chemotherapy in. And on laparoscopy, again, we checked just in case, and yeah, it wasn't resectable, but he got his HIPEC. He then, a month later, was offered again the same options, chemo, immuno, or a clinical trial. We had the same discussion. This time he said, I don't want chemotherapy. I know about immunotherapy, but if you got a trial, I did well before, can I try one again? It's a good lifestyle thing. I want to be able to, play sports with my kids, and I'd rather take a pill than get immunotherapy with potentially unknown side effects. So he started on a trial of an oral TEAD inhibitor. Side effects include increased urine protein. And he continues on this trial for over 2 years. He no longer needs the monthly paracenteses. He no longer has GERD symptoms. His disease is more than 30% smaller. Basically, at every CAT scan, it gets about 2% smaller. And he is fully functional and quite happy, and I hope he can continue on this study for quite some time. So that is a germline unresectable case.
So Hedy, that's quite a remarkable case. I think there's some things we can take from this. I think one, the thing that stands out is here's a gentleman who made the choice, even though we recommended treatment, he said, I want to be observed. And I think the key for all of us is we have to respect patients' decisions. You do and go through this disease on your own terms in terms of whether you want surgery or treatment or when you decide to act or not act. It's not compulsory that you get on therapy. You have to appraise what you want, look at your own history, and make decisions. And he had a significant amount of time after the interventions that were done before he faced having to go back on therapy. And I sometimes say patients are smarter than us. Like sometimes they make these calls and you're just like, wow, you just made a great decision. And we're looking at it through the prism of science all the time. So I think that's paramount in a forum like this. And then I think the other thing that was interesting, there's always this debate about what does HIPEC do, but if indeed the laparoscopy said that his CC1-2 was cleared when they went back and looked, it argues that there was a therapeutic effect in that synergism of the systemic therapy, the surgery, that went down. And I will say that I brought people back for second looks that have HIPEC and know that there's miliary disease and it's gone and it's just scar. So there is this, because we don't have clinical trials, major clinical trials that sort of appraise the response, but there are definitely responders in there. And then I guess the last thing I would say, the two things I'd ask you, Hedy, are one, if you could tell us a little bit about the TEAD inhibitor, how that works. That was one thing I would want you to do, if you don't mind.
Sure. So this is a very exciting class of drugs, and there are several different drug companies. Oh, sorry. Hello? All right.
Is a delay.
Got it. All right. So I can, take care of patients, but can't operate a microphone. All right. So I'm not here to advertise drugs or trials or anything, so I'll just talk about this as a class, and there are several different drug companies that have drugs of this class. And so we think about this as a drug that targets one of the abnormal molecular on-off switches. And so in meso, most of the growth switches are actually off switches, whereas in lung cancer, they're mostly on switches. And it's kind of a complex pathway, and this hits something called TEAD pamidylation. It hits something called the hippo-YAP pathway. And it was thought initially to be something that was useful for patients who have what we call NF2 deletions, but now we know that they work even in patients who don't have these NF2 deletions, and so exactly the molecular mechanism is not fully clear. I would say that these several of these are in what we call phase 1b expansion cohorts. So these are trials where they're testing in multiple different diseases and at multiple different dose levels to find the right dose. This particular drug is moving to a phase 3 trial, which will be a hopefully drug approval trial in which patients will be randomized to this drug or other drug or standard of care drugs. So they are promising enough. These data were recently presented at an international meeting and definitely show great promise for this disease, one of many classes of targeted therapies that are really exciting these days.
Awesome. And then the second thing I would say, so if this weren't a germline mutated patient with bicavitary disease, how might this impact the decision making and sort of the course that we're observing? How does that BAP1 germline mutation sort of impact this case versus someone with bicavitary disease with wild type BAP1?
So we actually don't know that. I know of other BAP1 patients on this trial, and I think that needs to be analyzed and looked at. Certainly patients with BAP1 germline status, as this gentleman is, have more indolent, slower growing, low grade disease, and what is the impact of a drug that might take a while to work, being able to do that in somebody who had slow growing disease, as opposed to somebody with explosive disease. Maybe it doesn't have time to ramp up enough. But I think we'll have to do analyses of the patient cohorts to know that.
Gotcha. And just the general tenor of this progression, if this would have been a wild type case, do you think we would have seen this same level of survivorship in someone with bicompartment disease with a intermediate to high grade, or Mike can speak to that as well? Like, have you had any bicompartment disease that are not BAP1 disease? And
if BAP1 germline wild type in a male with a high disease burden in the abdomen and involving the chest, it's probably a more kind of aggressive disease course. I think the BAP1 germline here is a very important portion of this specific patient's long-term outcome.
I think there's also a difference between the patient whose disease is predominantly in the peritoneum versus the patient whose disease is predominantly in the chest and then moves to the peritoneum. It's the one that starts in the chest and moves to the peritoneum. That's usually a more advanced disease. The patient who starts in the abdomen and might have trivial disease in the peritoneum, in the pleura, you might still, if they're very symptomatic in the peritoneum, have ascites, et cetera, you may choose to operate in the peritoneum, whereas you would generally not do it in the reverse of a non-germline patient.
Yeah, I wanted the non-surgeons to speak to these things, where it starts and the different factors that impact how the course will go. Georgios, any thoughts?
Two things. First, that I wanted to really highlight what Jason said before, how this has to be a conversation constantly with our patients, their families, not only for the reason that it is the right thing to do, but also because we have limited scientific evidence to help us guide what we do. So I always bring the example with my patients about the comparing this to, say, breast cancer, and those of you in the room who know somebody who has gone through breast cancer, there's so much literature there, so much knowledge that I jokingly like to say that we know if it's better for the patient to walk in the room with the right foot first or the left foot first. In mesothelioma, we don't know nearly as much, and in peritoneal mesothelioma, even less still. So I like to keep a little bit of an open mind, and in this case, the patient made a very reasonable and, in retrospect, a very correct decision by going potentially that route. But it is very important to know, and for us, kind of sitting on this side of the panel, acknowledge our limitations in what we do know and what we don't know and what we think we know. The second thing I wanted to really highlight, which everybody else has already, even though this is a wonderful, inspiring case, it is not the average case of the patient who comes in with a bicavitary disease. I think two things that will probably drive this home is, one, you had diagnosed pleural disease in 2018 or 2019, for which essentially he didn't get any treatment until 5 years later. So something that will ring true to anybody in this room who, again, knows of pleural mesothelioma. How many patients can go 5 years from diagnosis to first treatment? So there's something there that we have to use as we think about how some treatment worked or another didn't, is he was fortunate enough to get years out of observation alone, which is, again, wonderful, inspiring, maybe helps us identify different patients that may be getting similar treatment approaches. But I would caution against not using this as a benchmark to feel bad if we don't achieve the same outcomes with other patients, because that's unfortunately not nearly the average.
What's also interesting for this case is that we were just learning about the natural history of germline BAP1 disease during this course. I mean, this has not been identified for very long, and so we didn't really know how indolent this disease was, and we learned so much from our patients. But indeed, and I really agree with you about the whole joint decision-making on patients. It is so very important. You need to hear that patient voice.
100%. Yeah, we'll have Georgios come up. I guess my final thoughts, I think the panel's done an excellent job just talking about all the angles of this particular problem. So I think we'll go on and do another case. This one will have more of a recurrence flavor, I believe.
Okay. Wonderful. Yeah.
The doctor for on that patient, usually the ascites starts growing once that happens. I'm assuming the ascites problem was very minimal with him to not be disturbing, or were you draining fluids out periodically?
While he was on the EZH2 inhibitor, he was getting monthly paracentesis. And then towards the end, as it was worsening, he was becoming much more symptomatic, and that was why we did the laparoscopic HIPEC. Now he hasn't needed a paracentesis in 2.5 years.
Excellent.
And just to put a pin on that, that was one of the things that was very unique about this whole course. It took a long time to get symptoms, but we don't see that in the non-BAP1 patients. Usually symptoms start coming on pretty quickly, and they can be rate limiting in what we can do for patients in terms of symptom mitigation to get them on meaningful treatment or interrupt those things that may or may not be of benefit. But that's a great question and a good point.
Great. Next patient that I'll be discussing is that of a 26-year-old man who presented with a palpable abdominal mass and abdominal distension. And the first CT, before we even saw the patient, the report talked about diffuse nodular mass-like thickening of the peritoneum, so most pronounced in the right upper quadrant with small volume ascites. So a lot of terms there. But what this means is that when we looked at that scan, we saw some areas of some pockets of fluid, and then the omentum, which is that layer of fat we all have draped over our intestines, was thickened. So that is that caking that Jason mentioned before. So at this point, and without having much more information, I'll ask, I guess we'll start from the other end. Mike, what are you thinking right now? I don't want to follow the same pattern here. So what would be your first thought at this point?
Do you have a confirmed diagnosis yet?
See, one person falls into the trap, and now everybody knows. But again, when I was preparing these cases, I thought that the pattern was already established. So this patient does have epithelioid mesothelioma. And in fact, before even that referral, this happened in a local setting, had a laparoscopy for mapping out the disease and obtaining biopsies. And at that point, care was transitioned to a referral center. So what would be your first thought? And again, I don't have all the pictures here, but this probably does it justice from one slide. You have, again, diffuse disease. Jason, what are your thoughts on that? Where do we go to next?
You know, so in these scenarios, there's always a desire to repeat the laparoscopy to see it with my own eyes. But if I have good photos from the outside, and this is fairly diffuse disease, and I've talked to my pathologist, this is high grade. And I'm talking with my medical oncologist, just as the other case we discussed, that we're going to go down the path of some upfront therapy, reassessment. But I think this patient at that age, surgically, fitness-wise, is a candidate, and we just need to get them through the first phase that they're not going to have explosive or progressive disease would be my steps.
And then something you alluded to, like even if I meet the patient first or the surgeon meets them first, the utmost importance of having kind of a multidisciplinary discussion, even if the a priori thought this surgery doesn't make sense. I always like to tell my patient, I'm a car mechanic, he's a boat mechanic. We both look at engines, but we look at them differently. So like, I like the surgeon to meet them. We kind of come up with a plan together, but I agree, this would be some sort of systemic therapy. The other thing, if you have adequate tissue, would be genetic testing, inherited and tissue. And then something not yet mentioned, but just important, specific to peritoneal. There's a rare population that may actually have an ALK positivity, which is a specific gene we talk about a lot in lung cancer. So it's something that should be looked at, and next generation sequencing, or at least targeted sequencing in this disease, is actually considered standard.
Yeah, and all excellent points, which I think apply very well to this gentleman. So he did receive chemotherapy first with cisplatin and pemetrexed for 3 cycles. The imaging did show good response, so we did proceed to surgery later on, where in that case, cytoreductive surgery included a significant impact on the patient with having to remove the spleen, the gallbladder, part of the liver, and part of the colon, along with the lining of the peritoneal cavities in the affected areas. The PCI, which we just discussed, ranging from 0 to 39, or I guess technically 1 to 39 if you're diagnosed with the disease. In this case was 29, so fairly extensive, but the ultimate outcome was very satisfying in the operating room, right? So we were able to achieve a complete cytoreduction. And even more interesting is when all these areas were looked at by the pathologist, there was mention of excellent response to therapy, with a lot of the parts of the tumor looking like they were no longer viable. So we completed the recovery from the surgery was uneventful. Our version, or our, I guess, flavor of adding some chemotherapy to the peritoneal cavity directly after treatment is not necessarily in the operating room, but rather in the post-operative setting, where patients have a small port in their abdominal cavity, and we use that port to administer additional chemotherapy, in this case cisplatin and mitomycin C, for another 4 cycles, which went well. So at that point, what are everybody's thoughts? How often would they want to see a patient in this scenario, and what would be going through their minds in terms of risk of this coming back?
You know, this is a high-risk patient for relapse for sure, and, you know, standard general oncology boilerplate is every 3 months for the first year, every 3 to 4 months for year 2, and, you know, the first 2 years are the high hotspots. I tell people 75% of the recurrences, if you're going to recur, are going to happen likely in the first 2 years, and ideally, if I'm thinking about another intervention, you want to get them through the first year. It doesn't mean you can't offer patients with isolated recurrence is something, but you want to see some biological control some period before that happens in these recurrent patients would be my thought. But I don't think the patient needs anything else after this other than surveillance.
I agree with that. I would also keep in mind with the surveillance, like if they're having a good response, the fact that they are young and of childbearing potential, the modality of the imaging, contrast, things like that as well. So you always want to take into account the patient in front of you in terms of picking the imaging modality.
Yeah, so I think all these are very important things to highlight, and I thank everyone for making these points, because it's not, the course doesn't end at the end of the treatment, right? We still have what comes after, which sometimes is both less well-defined, but also can be more stressful, and checking more often or less often can be a double-edged sword. Now, this patient, unfortunately, despite everything going well enough at the time of the original operation, 18 months later, has another CT scan that shows several areas of concerning for recurrence. One was behind the liver, in an area that you can see there with a green arrow, but also some nodularity or small spots of involvement in the abdominal cavity. So we've gone through these treatment options. We are here now. What are everybody's thoughts? And I should highlight, just before I frame this a little bit better, that the areas of nodularity in the lower abdomen were actually more limited to one part in the pelvis. So, Mike.
So, I mean, I would obviously discuss it with you to see if there was a role to repeat intervention. The fact that this person had a quite nice response to the initial chemo, and it lasted, again, the caveat that there was surgery in between, but they had a meaningful benefit from that intervention. I would consider recycling the same type of chemotherapy, or immunotherapy could also be considered, but again, an open discussion with the patient would have to be had.
Yeah. Hey, do you share the same thoughts, or is there a limit to how much chemotherapy, how much surgery, how much immunotherapy? What?
So I would, of course, have a discussion with my surgeon, and she might want to do a laparoscopy to take a look to see how much disease there was, or she might not. We have that discussion together, and the patient may or may not want that. But indeed, I think that this patient is platinum sensitive, and you do kind of want to stretch out the surgeries if possible. And so it might be worthwhile to offer a platinum-based treatment. If, however, a clinical trial were available, that also could be an option.
It's, again, an excellent point about keeping those clinical trials in mind all the time. As I said before, we don't really know what the right treatment is at any given point as well as we would like, and the only way to overcome that is by studying it in a proper way. Now, the patient, and I will say I'm not exactly sure what the conversation was on the treatments before surgery, but eventually was taken back to the operating room for repeat cytoreduction. And at the time of the surgical exploration, the procedure had to be stopped because there was disease that could not be safely removed. There were vital structures in the abdominal cavity that were involved that did not allow the surgeon to safely clear the disease. So stopping there now, and let's just say that both Jason and I have agreed that this is not something that we could take out at that time. What do you have to offer the two medical oncologists? Or Jason, you seem like you have a comment.
Yeah, I just wanted to say, as Hedy and I were just talking, you can try to do a laparoscopy, and we can. Sometimes we get lucky after a high pick that's been formidable, and you can get in and get good views. But in these scenarios, when I know there's going to be a lot of scar that they faced, I may reflexively just talk with my oncologist and say, you know what, let's test this biology first before I subject them to at least in my thinking with these patients, I know that they required systemic therapy to get us there the first time. So why wouldn't that be true in a multi-site recurrence? Let's see what these things do. And then can we treat to maximal benefit before we go in? Because you're going to deal with scar and be back in some difficult planes. Back to the oncologist in terms of what they would do now, post-op.
Yeah, I think in general, like we had said, platinum if able, just because they had a very nice disease-free interval with the platinum. Immunotherapy is also not incorrect, but it would be a discussion about with the patient which one makes sense.
Yeah, and this is, I think, an excellent illustration of how it's so difficult to define what the right treatment course is, or how a lot of reasonable individuals can disagree. This is from our institution, but neither myself nor Mike were involved. And then the next thing that happened was the patient who got on immunotherapy. So not what we would have discussed on this panel before, based on the excellent treatment. Had you asked me, I would have said the same thing, that, hey, chemotherapy worked so well the first time, why not give it another go? I'm not sure if the rationale was there were toxicities that came the first time around that made the patient really hesitant to go back on that. Mike, maybe you know the
I
answer to
reviewed
that.
this case for the paper. It had just become recently available in that space, so it was like a hot off the press drug combo, and the patient very much wanted it.
Yeah. So interesting thing happened next is first we always think about immunotherapy, and this is I was hoping this presentation can help give a little bit of a counter to some of the common, I wouldn't say myths, but common misconceptions we have about one treatment versus another. We all think, at least on our perspective, and I suspect it happens across the board, that immunotherapy, stimulating the immune system, probably less toxic than getting chemotherapy, which is essentially poison, but well intended. However, this patient, as their course showed, they developed thyroiditis, which essentially knocked out their thyroid gland and needed to have thyroid hormone supplementation from there on, and also developed diabetes that was bad enough to lead them to an ICU admission and get ketoacidosis. So not, obviously, again, this is, we're talking some outliers here, same as we said before, that case was not representative of every case of disease involving both the chest and the abdomen. This is certainly not representative of every case of patients receiving immune therapy. But things can happen out of the ordinary. The scan after the treatment was, or the intended 8 months of treatment were completed, showed no change. So at that point, and given the patient's young age, their overall overall thought process was to give it another try and see if at that point, even though the imaging response was not certainly very impressive, the fact that there was no progression in the meantime. And we also know that sometimes immune treatments can have responses at the microscopic level, but not always necessarily at the level of looking at a scan and changing what we look at. The decision was made to take this patient back to surgery. And something interesting happened there. The patient had another exploration, and things looked to be much, much better, dramatically better, in fact. All gross disease that could be seen, anything that could be visibly seen with a naked eye, was removed. And from a clinical perspective, this was judged to be an excellent clinical response to immunotherapy. Now, I will say, and I just put an asterisk on this because that could be a whole talk for about an hour, when the pathologist looked at those slides from the specimens that we sent to them, or that the surgeon sent to them at the time, they said that they couldn't see anything that reminded them of response to treatment. They looked like it was pure tumor, the same way that they were expecting it. Now, what does that mean? How does the immune treatment effects we know that they're going to be different than a chemotherapy effect, but sometimes you can have a lot of discrepancies. So it's not uncommon for your physician to tell you that the tumor is responding, and then your pathologist to tell you the opposite, or the other way around. Sometimes we see on pathology that once something is taken out, it looks dramatically different from what it was before, even though the CT scan, as in this case, looks the same. So the surgery this time around, again, was felt to be complete, and thankfully the patient 2 years later remains without any signs or symptoms of disease on continued surveillance. So the one thing that I wanted to kind of delve a little bit into in this context is, when do we consider somebody for repeat surgery? And this is something that I've been asked many times. I've heard this is a one and done surgery, or I've heard that one cannot have it again. The reality, like most things in life, is much more complicated than that. There are certain things we know are going to work better, and certain things we know are going to work worse. So, for instance, somebody having one small spot versus a lot of them, or having smaller versus larger spots, or those spots. And perhaps to me, that's probably the most important factor here, is having enough time between one surgery and when you're considering the next surgery. And I will explain a little bit why that is. The biology, we talked about some cases today that have favorable biology, BAP1 germline or other different subtypes. Of course, it's important to know, do we think that we can achieve, again, a complete cytoreduction? If we think that we're going to surgery but we're not going to be able to do that, the trade-off is not always warranted. And then finally, the fitness of the patient and their ability to tolerate this. But putting all those things together, the way that I try to rationalize this is, if we know that surgery is going to give somebody a few weeks, sometimes a few months of a recovery period where their quality of life is not going to be as good as it was the day before their surgery, what is the is the expectation that what they will get out of it, whether it is through living longer or living better once the recovery has been completed, enough to justify this. And that's where, for instance, that disease-free interval is so important. If doing a surgery that you need 3 months to recover from, or 2 months to recover from sometimes, leads to you having a CT scan that looks no different 4.5 months later, is this something that you feel is a good trade-off? And again, for everybody in this room and everybody on this panel, the answer may be different, but that's, in my opinion, the way to approach this rather than a yes, no, or strict criterion. And the outcomes after repeat cytoreduction are actually better than one would think just thinking about it. But it is very important to know they are as good as they are, because not everybody who has their tumor come back after the first cytoreduction is offered a second one, right? So by definition, we as both patients and providers selecting a treatment that we think is going to be reasonable, and I think the outcomes show that we are fairly good at selecting a reasonable treatment, because people who do have that second cytoreduction, who choose to have it, do fairly well. And the safety profile is not that different from that of the original surgery, which means, again, if we do the right thing at the right time for the right reasons and with the right patient, it should have a very similar outcome. Recurrence is still very common, unfortunately, same as the first operation. Sometime between 1 and 2 years is when we tend to see things come back. So again, the one key message to highlight one more time is this: repeat surgery is an option, and it's appropriate in highly selected patients who have both who have a good biology or a favorable biology, good performance, and disease that can be taken care of. But again, highlighting the importance of having that done in a context of people who have the both individual and institutional experience for that. Do we have any comments from, or should we move on?
Yeah, I guess I would just say, forgot what I was going to say, actually. I'll let you go if you had anything to say. In these recurrent patients, this is a challenge. I think the idea that they can undergo multiple procedures more than once. Like, I've had patients who come back a third time for an intervention. So I don't think limiting the number of times, it's more about the context, as you said, is where I wanted to go. And then the other thing that was rattling in my head as you were talking about this, and it also goes back to some of the first cases I wanted to ask our oncologists, with the increasing efficacy of immune therapy, so for instance, the standard patient that we're going to do neoadjuvant chemotherapy on, how do you choose or not choose to add immuno? Is it routine? Is there a certain context? And similarly, in the recurrent patient, the choice to just do immuno or to do combination, like what's your preferred way to manage these patients now with these tools at our domain?
So, I mean, as we've all alluded to, this is somewhat of a limited data zone, but we have more experience comparatively in plural. All things being equal, outside of a clinical trial, chemotherapy is the one that's most studied in terms of outcomes. If a person had something that would make me think immune therapy would be more beneficial, be it the swirl histology or things of that nature, or patient preference also obviously comes into play. If a person has kidney issues or some reason, I would be nervous to give chemotherapy. For the most part, the conversation I would have is the most studied and standard of care is chemo perioperatively.
Yeah, we really have, 3 or 4 different options. We have plain old chemo, we have plain old immuno, and we have chemo-immuno. There's even less data on chemo-immuno in the peritoneum, although there is a large randomized trial. But in general, when choosing between chemotherapy and immunotherapy, in addition to the patient-related factors, do they have kidney disease, do they have autoimmune disease, it's also a predictability of toxicity and a length of treatment issue. Because chemotherapy, you know what day you're going to have nausea or constipation or fatigue, and that cycle is predictable. With immunotherapy, oftentimes you may have less toxicity, but the side effects are much more unpredictable, and you just don't know which organ system is, your immune system is going to take a left turn on, and suddenly you've developed inflammation of this organ or that. For some patients, they want something that's tried and true and predictable. For other patients, the issue with immunotherapy is that if your immune system is activated to target the tumor, sometimes it can work for years and years, and whereas chemotherapy tends to work for a shorter period, though not always. So you really have to balance that. And there's better data for germline patients with platinum, and so those are patients who you might encourage chemotherapy with. So really it's a balance of patient factors and patient preference.
So I just put this in there because of the IP therapy that was given in this case, and I know Memorial has a trial where they're enrolling optimally cytoreduced patients to IV-IP versus IV alone, and several centers are participating in this in terms of the mechanisms, in terms of whether or not it gives us better disease control or has an impact on survival. He covered all of these in terms of sometimes this is called iterative surgery. And to the point that I made, that patients who get second cytoreductions, they're often candidates if they have isolated recurrences or limited recurrences for a third or a fourth round, and there's probably some people in the audience that have had that done on more than one occasion with their disease. So we're going to move on to our other panelist, Dr. Offin, who's going to present an unresectable case and its management.
All right, hello everyone. So this, for those of you that were here 2 years ago, is actually the same case. It's an update, so she's actually still doing quite well, so she's watching at home. So this is a patient I met basically 5-6 years ago. So she 61, otherwise relatively healthy. This was in the midst of the beginning of the pandemic. She started having abdominal discomfort. For many, a pandemic level reason, imaging was very difficult, and so there was about a year gap from symptom onset until initial kind of ultrasound imaging. It showed a quite substantial mass that kind of spanned the entirety of her upper portion of her belly. She did have an exploratory laparotomy to take a look. Again, the diagnosis wasn't known at that time, and they found extensive peritoneal and omental implants along the diaphragm. This is around the time she came to Sloan Kettering for her opinion, where she sought care. So the pathology review was that of an epithelioid peritoneal mesothelioma. I put this little portion here. Pathology reports don't just give you this. They give us like very specific markers and stainings. That's becoming more and more important as we learn about these potential therapies on trials. That can be exploited, like if this is lost, try this medication. So these panels evolve annually, basically. This is just a kind of what we would get on our somatic panel. So we tested for 500 plus genes, and we found 2 in the tumor. We tested 100 genes in the inherited setting, and she had none of those. So no BAP1 inherited loss. The BAP1 she had was only lost in the tumor. She saw my GI surgical colleagues, and they felt that she was borderline resectable, and we all kind of came to the decision, the patient as well, that giving her something preoperatively to see if we could control the disease and figure out the biology a bit better would make sense. So we ended up giving her 4 cycles of platinum and pemetrexed, which thankfully she tolerated pretty well. Repeat imaging, according to the scans, looked like she had a nice response. So we did do an attempted cytoreductive surgery. But unfortunately, there was a large amount of fibrosis and adhesions. And as Gio had mentioned, in the operating room, we were kind of convinced this was hopefully scar and treatment response. But we did find a lot of viable tumor. An important caveat of this is in mesothelioma, we don't have a good definition of pathologic response. So if you're thinking about like a solid tumor, a lung cancer, a breast cancer, it's a ball. You give medicine, you take out the whole ball, and you can see what % of the ball is living and what % of the ball is dead. So you have a numerator and a denominator, and you get a %. But in mesos, when you go in, even if you take the entire lining off, people assume it comes off in a solid piece. It comes off in hundreds of little slivers. And so you don't actually have a denominator. And then the cells themselves actually can look fibrotic and things of that nature. Is it response, or is that just the tumor that looks like that? So understanding what is or isn't viable tumor, what a path response is very understudied in this realm, despite lots and lots of ongoing efforts. So operatively, we thought it was scar. Under the microscope, there was residual disease. She still had relatively robust symptoms. We gave her a period of time of observation, but within basically a scan or 2, the disease was already regrowing. And so we decided to try immunotherapy in that setting. She did not tolerate immune therapy well. She didn't have any specific side effect to put her finger on. She was just extremely fatigued and a poor quality of life. And then the imaging overall eventually showed progression of disease with lung involvement. Because she had some response to the chemo on pictures and no response to the immunotherapy, I put her back on chemo. And she had a very robust response radiologically. We kept her on the Avastin, and she had a beautiful quality of life for a year and a half, and then came in with hip pain, and we actually had caused the bone in her hip to not get enough blood flow based on the Avastin. So she had to get a hip replacement, and we stopped the Avastin. This led to a period of time of surveillance, and that's actually where I left it 2 years ago. So we got away with about a year of surveillance, and then unfortunately she did develop symptomatic recurrence of her disease, abdominal discomfort and pain, chest discomfort. We discussed several options, and similarly, I'm not here to work for a pharmaceutical company, so I'm not going to say the names, but I put her on the same TEAD inhibitor trial, and she actually had a complete response, and she's still on it well over a year later, so we can't see the tumor anymore, and her pain is resolved. It's important to say the 2 cases we've discussed are the best case scenarios of that drug. It's still being investigated. It doesn't work for all. But for those it works for, it can be very important and transformative, and it's a very exciting field of research, but it's just that, it's still research. And the big takeaway I get from this is, for a long time and still, peritoneal mesothelioma is the orphan diagnosis of an orphan disease. Like, there are more trials for pleural than there are peritoneal. And so I think disease-specific trials or mesothelioma trials that allow patients with either type of mesothelioma that we can analyze separately are 100% paramount here. Because peritoneal disease, for the most part, we're relegated to basically whatever we did in pleural, we'll try it in peritoneal once it's approved. This drug and drugs like it, they're specifically looking at peritoneal versus pleural, different genetic factors, and that should be the next iteration of these trials. We should have respect that these are 2 different diseases, and they can have different outcomes. So the reason behind this case was we kind of exhausted the most attractive first-line options. We also had her ready for cellular therapeutic, a CAR T trial. So again, discussing trials at every point is always an important standard of care consideration. Like when you look at the guidelines for the management of mesothelioma, they'll list a bunch of the drugs we have, and right next to it, it'll say clinical trial is also an option. So I think this is an illustrative case of that kind of possibility. I think I probably forgot to advance, but I kind of verbally said what I wanted to. So again, just to reiterate, this class of drug is exciting. It is not standard of care, and so I just wanted to be careful with that. There's a lot more investigations ongoing, but this is an exciting time for this type of a oral option drug.
Thanks, Mike. That's a great case. I'm just going to do one more case in this arena, a unique case that I had. Similar scenario of an unresectable patient, and I was able to figure out how to put these in, so I'm going to play this, and you'll see here, if I pause, how severe some of the things we've been talking about. So you can just see up here, this is small bowel disease completely encased on this individual right here, who came in, who actually was fairly asymptomatic after COVID. Just had this unexplained weight loss and just extensive disease. And if I click on this one below, you can see the small bowel is the limiting step all the way down to the pelvis. So this is a gentleman we would all say isn't a surgical candidate, most likely won't become a surgical candidate. And this is sort of on that era when immunotherapy was starting to get a spot as a possible treatment option. So I'm going to bypass this just for the sakes of time. This is a gentleman who, as we would expect, went on systemic therapy. There was a lot of difficulty getting the Keytruda, the pembrolizumab, approved for this patient, but we did. And the patient was actually having some response, but again, this is another episode where these patients with high burdens got a DVT, this time lower extremity DVT, went on appropriate therapy, then had a GI bleed, and we all encounter that when people have GI bleeds, you have to hold the blood thinners. So our natural instincts are we want to protect them from a PE. When we protect patients from a pulmonary embolism, we put something in called a IVC filter. It's a little net that catches any clots so that they don't go to the lung. those are not benign either. And unfortunately for this individual, they developed extreme clot burden in the cava with massive lower extremity edema that required another one of these vacuum-assisted thrombectomies. And just as a side note, like our ability to take care of patients with these issues that often would have been life-threatening has just gotten so much better, whether it's an IR person or a vascular surgeon who can declot some of these clots that would require open surgeries. And it's a game changer because we do see this in our oncology world. So this individual had that, was able to successfully get back on Eliquis, was doing well, but some of the things that came up was the toxicity of immunotherapy, the unpredictability of it. And one that I had not seen was itching. Like I had not seen someone like itching to the point where they were scratching their skin off. And that can be, you take it for granted that itching happens and we just scratch. But if people who've had these immunotherapies, it's unbelievable how much itching and skin reaction that they're having. And it can be a reason to come off of therapy. Often it can lead to other things such as diarrhea and colitis, and that's what this individual had. So this individual came back, and that's what this shows. As I run through that, I can do it again just to kind of show you that what happened in all of this is that he had an unbelievable response over 18 months. And it allowed us to reevaluate his surgical candidacy. Most of his symptoms had been down in the lower extremity, but he became a candidate. So we took him back after this extensive treatment, and he was unresectable. Again, this was palliative in nature because he was already considered somebody who wasn't going to be treated for cure. I put these specimens in. I'm going to quickly go over it because it might bother folks. But we ended up having to do lots of bowel resections. We ended up having to take out multiple areas where the bowels were stuck to this. But it turned out the therapy actually sort of took these things back. The way I view it is you get back to the root of where these tumors started. Where were the original implants, the way that these things can work? Now, whether or not it was the immune therapy or the chemotherapy or the combination of both, it got us to this point. And this gentleman went on and had significant control, ended up having to go back on single agent immuno. Again, the itching was a little bit better at about 18 months down the road. So I do think we're in a different era. Like some of the things that have come up that you've heard here are sort of changing the paradigm for cancer control and potentially surgical candidacy at different points for people. And I think this is the thing, it's always a conversation. Georgios and everybody said that we're constantly having conversations about people's options and also listening to the patients about what their desires are, what risks they want to take or not want to take with this, but they're in the driver's seat. So I'll kind of close here, and hopefully these cases were illustrative of where we're going with these things, what our options are, and sort of the importance of just this open communication and being earnest about how you're feeling and everything else. We didn't talk about symptoms in terms of those things that come up and how we can use surgery and other things for that, but I imagine we may get some questions in that arena, but we'll open the floor to the audience.
Dr. Forster, in our patient group yesterday, there's 4 or 5 of long-termers that were in the room, and everybody else is either here for the first time or maybe the second time. One of the comment we made was they have so many more options today than we had 10 plus years ago. And I'd just like to thank the panel and all the doctors that are in the room for making that a true statement. I really do appreciate that. So I don't have a doctor in front of my name, but in I think Dr. Kindler's case, I heard a term laparoscopic HIPEC. I've never heard that before. When did that come about, and why would you use that as opposed? I think I know the answer, but I'm not going to embarrass myself.
So I defer to my surgeons as to how long that's been going on, but this was a case where the patient couldn't have the full cytoreduction to try to remove everything, but was symptomatic from ascites, and the chemotherapy, the hot chemo that goes into the peritoneum, can in some situations control the ascites even laparoscopically. So we wanted symptom control, and that's what we were looking at that point.
Hedy, the non-surgeon, is right on with that, is that you're trying to mitigate toxicity of the procedure. And if you can get access to the abdomen, and often ascites is a free pass, like they're already opened up, if you had a lot of adhesive disease, those adhesions are taken down by all this fluid. So you can literally, and they've created a space in the abdomen for you to view. So laparoscopic HIPEC's been around for decades, maybe two, where people have tried it. In the sense of local control, it's in the sense of controlling a symptom like ascites. And it's been pretty effective. Like, we know that ascites can be controlled with HIPEC, but it doesn't remedy all the disease. And the other thing Hedy mentioned, and this is popping up at lots of institutions, is PIPEC. This idea of going in and using an aerosolized form without heat, because there's an argument that PIPEC can give you a broader distribution. I would say it's very much, I would call it in the very embryologic stages of where it sits and what its value is next to HIPEC, which has had decades and decades of value, particularly in this disease. But it's definitely another modality, and it has this ability in unresectable patients to be done on a repeat basis. There are some other cancers where preoperative repeat HIPEC is being done to try to turn people into cytoreductive candidates as well. So there's a whole area of research and investigation that are done from center to center in terms of what people are doing.
So I have a question about 55-year-old male with epithelial, peritoneal, with CRS chemo and then CRS HIPEC with a CC of 0 almost 2 years ago. He's at a facility that's repeating with CTs every 3 to 6 months, 3 months right now. And I mean, hopefully he lives many years. So is there a role for asking them to switch to MRI due to the radiation exposure?
I will tell you, I don't think MRI is better than CT. I think a lot of the way this works is institution. If your radiologists are skillful CT readers and they have protocols that enhance their detection of peritoneal disease, they are equivalent. Well, I guess since I have both modalities at my institution, I have the luxury of testing patients on both platforms to see which one gives me the best information. And I can't say that one is better than the other in terms of detecting or telling me what's going on. There are times where I get MRI and I see a bit more, and surprisingly, there are times where the CT shows it more clearly. So I would say it's on a case-by-case basis. I think if there was ever an interest, these things can be obtained, like we share our protocol if someone wanted to pursue an MRI baseline. But it's always best to kind of use the modalities that you've been following patients with consistently to look for changes, and you can catch those changes. Now that is a valid concern. I will tell you, I don't personally have any experience where the use of CT scans as a screening modality led to any other adverse effect. But you are right, there's data about cumulative radiation exposure. The one thing that's happening in the radiology field, and it's happened at our institution, is the doses we use to get the data are continuing to drop and drop and drop. Like, we're getting higher quality CT scans with the technology with less radiation doses. And matter of fact, we just had another email come out at our institution that we're dropping our doses again, and not to be worried that our quality was going to go down. So I think the radiology community is very much interested in that. I'm not a radiologist. I don't know if the guys get into these conversations at all, but it comes up with us every once in a while because people get a little antsy that their quality is going to go down.
I mean, in general, if the patient brings it up, we can always discuss it. There are certain genetic risk factors that may push us, like Lee-Fraumeni, these like really rare genetic syndromes where they may be really sensitive to radiation. But in general, we tend to use CT scans more often than MRIs. But if a patient were to bring up the question, then we kind of, as was alluded to, could always get an MRI as a baseline to compare to and then see if it makes sense.
There's a lot more variability in MRI technique, and so you just want to make sure that the site where they are being done and the site where they are being read actually is qualified to do so. And at some places, it's perfectly fine, but at other places it's not. Whereas a CAT scan is a CAT scan is a CAT scan.
With respect to the itching and immunotherapy, I was on immunotherapy for 30 months, and the itching was phenomenal. I mean, I wanted to scratch my skin off. And just over the counter, cortisone cream was a lifesaver. I was going through a tube of this a week for 30 months. And I've been off immunotherapy since the first week of January this year. I still have the itching. I'm down to a tube a month now. And the other thing that helped was Aqua 4 helped too. But this was the best.
In general, never underestimate that the skin is the largest organ in your body. And so if you have even a mild side effect to it, it can be substantial quality of life concerns. Topical steroids, anti-itch medication like Atarax, also called hydroxyzine. We've tried nerve agents like gabapentin, and some patients can help. But in general, if the itching is really profound, always talk to your doctor about it, so maybe you can talk to a dermatologist.
I have a layman's question about the next generation sequencing. We just became familiar with that this year with my husband's treatment, and I was wondering how common that is now at facilities, hospitals. When did they do it? Who makes that decision? And is it only in the expert centers of excellence?
So theoretically speaking, it should be offered. So within the guidelines, genetic sequencing for both pleural mesothelioma and peritoneal is in the guidelines as a recommended consideration. In peritoneal disease, there are rare patients, like I had mentioned, that have a specific gene we have a drug for from lung cancer world, so that's been in there for a while in the guidelines to look for. There are commercially available tests, so like a lot of us here sit in the ivory towers that have these expansive labs that could do fancy things that other places may not be able to. But there are companies out there that will be able to literally FedEx a kit to a clinic anywhere in the United States or globally. Again, I don't work for that company, so I'm not going to say names, but we could talk after if you're interested. But you can have these tests run at a validated lab and get pretty good insight into the tumor. These aren't necessarily used to make immediate treatment decisions, except in, again, that rare case where we have something that's already actionable with the medication. But that level of data is the patient's right. It's reimbursable, and it, again, should be considered in all.
Thank you, doctors. My name is Diwas Reyamazi. I'm a caregiver. My wife, she has peritoneal mesothelioma, diagnosed 4 months ago. And Dr. Offin, he's well aware of it. He and Dr. Nass, they've been guiding us. So my question right now is, she's already been through 4th round of chemo. We have another one scheduled coming up 1st of next month, but she has imaging coming up tomorrow, a PET scan imaging. So will that PET scan provide enough information to decide by surgeon whether she is going to be a surgical candidate, or do we have to go through more tests for them to decide whether they can do a surgery, or is just the PET scan is enough?
So that type of a scan will give us a lot of ideas of, like, again, has it been controlled? Is it confined to one compartment? But there'll be a lot of other discussions that have to be done with the surgeon, pre-surgical testing, if the scans are adequate, CT scans, and even sometimes a repeat laparoscopy before committing to a larger procedure. So it's an initial kind of broadside of the barn view to see if it makes sense. I don't know if my surgeons wanted to comment more on like the pre-surgical workup.
This is always a tough question to answer, right? It depends a lot on what made the first scan lead us to say that this is not the right thing, or if it was laparoscopy, or if it was whatever the decision making that led us to say we should not start with surgery, is what ultimately determines how we're going to use the next parts of the information as they come in. To give two very different examples, sometimes we have patients who don't have surgery early on because they have been very debilitated, and their disease that we can see on the scans or on the laparoscopy is not prohibitive, but we want to give them a chance to get better. And sometimes those patients may start with something like immunotherapy, which again, although we discussed all the bad things that can happen, it can be sometimes well tolerated, and then they build up, and then that CT scan or that PET scan is used more of a exclusion tool to say, well, nothing bad happened during these times. Things didn't grow, didn't get worse. And as long as they are the same and you're better, we can go to surgery. And it's a very different scenario than the one that somebody has the true, as discussed before, borderline case where there is so much going on that we want things to shrink down before we attack them, in which case another laparoscopy or another scan may be the difference maker. So without knowing the details, there's so many different scenarios here that that may be part of the answer or that may be the main answer, if that helps.
And just to build off of that, like the details of the before and then the comparing of the before to the baseline set the stage for the goals of the surgical intervention. Is this a case where we're going to achieve an ideal surgical resection for a patient? And just to put a more specific detail, so if you get a PET scan and that PET scan shows diffuse lymph node disease in other places, your enthusiasm for surgery are starting to wane because now you're dealing with another compartment of disease that you can't control in the abdomen or with the scalpel. You need to start thinking about other options. I think sometimes as patients are going through therapy, there are symptoms from the therapy where people need a break, and you may take a two-surgical approach. It does come up because the symptoms of the disease need to be unpacked. They're having difficulty getting through therapy, so sometimes you can do, particularly if you get to one of these diffuse CC1 cases, and you can do operations without a lot of hollow viscous, when I say that, bowel resections, things that are going to make this recovery more challenging, taking out the omentum in the spleen and some of the peritoneal procedures that will unburden chronic ascites and other things that we face. I think immuno has been a game changer in that when it's added on in terms of remedying that, but there are times you'll strategize for patients. So it really is this customized approach, and it's one you have with your oncologist and your surgeon for that particular case as you move through.
Earlier with the next-gen sequencing, you mentioned that following treatment might change things with genes and so forth. How frequently should you have next-gen sequencing tests run?
It's a great question. From an insurance perspective, once. In certain cancers where we have approved, validated, targeted therapies, and that means like a lock and a key. If you have this gene, that's the lock, try this key, the drug, it should fit, turns it off. Well, eventually the cancer can outsmart it by changing the lock. And so in those settings, next generation sequencing being repeated to see how the lock changed is relatively standard in like the lung cancer world. In mesothelioma, we're just getting to a point where we may, the important word being may, have some therapies that can be considered targeted, TEADs and otherwise. And so this conversation may evolve over the coming years as we get, hopefully, some keys for this disease. As it stands right now, if I have a person who's had a long period of time between initial biopsy and then they have a recurrence, we will repeat a biopsy in the right setting to say, A, is it the same disease? Is it the same flavor? Or has it become swirl when it was vanilla? That kind of thing. And if you have the material, and you have the ability to run that material, again, there are insurance restrictions to the amount of times you can run the test right now. We do repeat it when we can, but I wouldn't say it's a standard approach. As it stands right now, one-time genetic sequencing is the recommendation. But again, at our specific, unique institutions, there are scenarios we do repeats, but I wouldn't say that's standard across the board.
In the setting of a clinical trial, you might then repeat it because there are certain mutations that might appear later, and so you might not have that mutation earlier. And if you want eligibility for that trial, you might want to then look for it at that point. It's again pretty uncommon, but it's certainly reasonable.
The other part of that, I think I mentioned at the tumor board yesterday, panels evolve with times. There are genes now we didn't know existed 3 or 4 years ago. So if, you know, you've been battling this disease for a long time and your genetic testing was 5 years ago, repeat testing or recapturing DNA from an old test may be necessary to find these newly identified genes. So it's always a good conversation to bring up when you're talking about trials, especially if the sequencing is very old. Was that gene encompassed on the old panel?
Well, thank you very much to our panel, and let's thank them all. We appreciate you being here very much.